Welcome guys to my video. Today we'll be talking about the pharmacology of the local anesthesia. So we'll be talking about the local anesthetic drugs used to numb a particular area if you want to conduct, but it's just that there's no total loss of consciousness. So we'll be talking about the local anesthetic drug today. So if you are new to my channel, make sure to subscribe and turn on your post notification button so that anytime I drop any video, you will be sure to be notified. And if you want me to make a video for you, make sure to write it down in the comment section. Once I watch it, I'll make that video for you. So before you come to local anesthetic, make sure you watch the skeletal muscle relaxant and the autonomic nervous system, because now the skeletal muscle relaxant and the local anesthesia, they are drugs that are acting on the peripheral nervous system, because I make sure I categorize them into groups. The first group was drugs that act on the autonomic nervous system. This one is drugs that act on the peripheral or somatic nervous system. So make sure to watch it in groups, and also make sure you subscribe and turn on your post notification button so that anytime I drop, you will surely see it. Do you get it now? Always share my video to all medical students. Let it reach far and wide. And once you have a question, just drop it down in the comment section and I will explain it to you and make a simple video for you so that you understand it. So let us drop right into the video. So welcome guys to another lecture today on drugs that act on the peripheral nervous system. We have talked about the skeletal muscles relaxant already under this classification of drugs that act on the peripheral nervous system. The next one I'll be talking about is the local anesthetic, or we call them local anesthesias. Like I said, they are the ones that are used locally to numb an area for the purpose of any clinical use. So that's what we want to talk about today. So first of all, we introduce what local anesthetic. What are they? They are a group of drugs. Okay, always remember, they are a group of drugs that reversibly will block a nerve conduction. So they reversibly block a nerve conduction when applied locally to a nerve tissue, producing loss of sensation to that specific area without a loss of consciousness. So we don't want them to lose consciousness like general anesthesia, because as opposed to general anesthesia, there's total loss of consciousness and you're using muscle relaxant to paralyze the patient, especially the neuromuscular or blocker. So but when you are using local anesthetic, you just want to numb that particular area by reversibly blocking the nerve at that particular area. So when you reversibly block the nerve, later after it you can unblock it back. So when they say reversibly, it means that it can be reawoken back, because when a nerve have stayed too long being numb, it can go numb forever, or it can go numb for a long time and it will be difficult to bring them back. So that's why I use local anesthetic, local, a particular area. So you don't want to lose consciousness, you just want to numb the area for a particular activity. So they reversibly block a nerve when applied locally, especially to a nerve tissue, producing loss of sensation in that specific area. Now, one thing you have to know now, they are acting mainly by blocking voltage gated sodium channel. So remember, anytime acetylcholine bind to the nicotinic and muscarinic receptor, what do? They open the ion gated channel and allow sodium to enter. Always remember. But what you want to do now, you want to block it. You don't want sodium to enter into it. You don't want sodium. So you want to block that channel, thereby allowing potassium stay inside the cell, while sodium do not enter. So when you block sodium, now there will be hyperpolarization. So depolarization will not occur, there will be hyperpolarization and the propagation of action potential along with it. Now, so there will be no depolarization, there will be hyperpolarization, which means there will be increase in potassium across that area, and if there is increase in potassium across that area, there will be numbness of that nerve. So we want to target the nerve, especially the sensory and motor nerve, which we call the mixed nerve. So we want to target these nerves in order to produce loss of sensation, not in other areas. So you can be awake while they are doing anything they want to do to you. It can be a surgery that is maybe in the teeth or in an area, maybe for those that write tattoos, maybe they are doing the surgery on that place, or they are doing the activity on that side. So you just want to do a specific activity, but you don't want to feel the pain. You get it now? So that's why they use local anesthetic. Don't forget, blocking the sodium channel and also reversibly blocking the nerves. So one thing you have to know, that cocaine was the first to be discovered. So cocaine was discovered in like 1860s. That is when cocaine. But now you know cocaine is now a menace now, because people use it and for drug abuse. But cocaine is very good before, because it was discovered as a local anesthetic and it worked perfectly as a local anesthetic. But people have abused it over time. So cocaine was first to be produced in 1860s, but it was used by Carolla. It was used by Carolla in 1884. But now he used it specifically for the ophthalmic anesthesia. So in the eyes, he He was an ocular doctor, so what he used is that he used it to numb the eyes in order to carry out a surgery on the eyes. So he used it for ophthalmic anesthesia in 1884. That was the first time it was used, but its discovery was about 1860s. Don't forget, for your exam specifically. But later, due to toxicity and abuse, I said it was abused later, so they later brought out some middle forms, which is Blockade. So Procaine was the first esters that was formed. So Procaine was later brought out. So when Procaine came in 1905, so they started using Procaine as the first esters or first synthetic to be produced. Then later, lidocaine, which is the first amide, was now bought. So lidocaine was now safer to use in about 1840s. But we'll be discussing the benefits and the disadvantages of all these things. Today, local anesthesia is using what dental surgery, minor surgery, obstetric, and what regional anesthesia techniques. So they use it generally for all these cases now. So under the classification, because we're talking about the classification of local anesthetic or local anesthesia. So what is the classification of local anesthesia? We'll be classifying them chemically now, based on their chemical what properties. So one thing you have to know that they can be classified as esters and amide. Don't forget, esters and amide. So because this classification is very, very important, because it determines their duration of action and their stability. So you just have to know which one is which, and you with using the mnemonic I'll be giving you now. So just be watchful. They are classified based on the type of what intermediate linkage that connect to what the lipophilic aromatic ring to the what hydrophilic amide group. Don't forget. So local anesthetic now is classified based on their intermediate linkage. Their intermediate linkage for your exam. Intermediate linkage that connect the what the lipophilic aromatic ring to the what hydrophilic what amide group. So there's in the aromatic ring there's a lipophilic, and in the amide group there's what hydrophilic. So don't forget. Why? Because lipophilic lipid are what hydrophobic. Are you getting? Why amides are what water soluble hydrophilic? The esters contains what COO. Don't forget COO linkage. So you see COO linkage in them. Why the amide contain what CONH linkage, which means the presence of what amino group there. So don't forget. So since we know this one now, so let us classify them successfully now. Once you know about esters local anesthetic, that they have one eye in them. So if you check the group now, they have one eye. So that's how you remember them. So when you remember the local anesthetic with one eye, you remember that they are under esters group. Example, you have procaine. Procaine has one eye. Cocaine has one eye. Tetracaine has one eye. Benzocaine has one eye. Chloroprocaine has one eye. Now in the amide too, they have two eyes. So they all have two eyes. Now you have lidocaine. There's one eye, there's two eye there. Propivicane there has two eye. Mepivicane has two eye. Pelilocaine has two eye. Ropivacaine has two eye. Etidocaine has two eye. Then atticaine has two eye. So you remember I have one eye and I have two eye. So one eyes are for what esters, while two eyes are for what amide. But one thing you have to know about the difference is that first of all, esters are easily what hydrolyzed. So they can be easily broken down by what plasma or pseudocholesterol. So plasma pseudocholesterol, which you call what butyric cholesterol, because they are not acted upon by what acetylcholesterol. No, because acetylcholesterol tackle acetylcholine or look alike, but this one is acted upon by butyric cholesterol. So easily, so all esters are acted. All those one with one eye, they are easily what broken down. And since they are easily broken down, they have a rapid metabolism. So if you are breaking down faster, you have shorter duration of what action. So they have shorter duration of action. Very, very important. And they are metabolized by what para aminobenzoic acid. Don't forget for your exam, they are easily hydrolyzed by what plasma pseudocholesterol, which is butyric cholesterol. Then they have shorter duration of action. And since they have shorter duration of action and also rapid onset, don't forget rapid onset and shorter duration of action, and they can be metabolized by what parabenzoic acid, which means they have what an allergic what properties. But in amide has a shorter duration of action. So amide has longer duration of action, but they can be degraded what slowly. So degradation is very slow. Why? Because they can be metabolized in the liver by cytochrome P450 what enzymes. So therefore they are less what allergic. Don't forget. So don't forget, esters have shorter duration of action because they are metabolized fast, while amide have longer duration of action. So the only esters that have longer duration of action is tetracaine. So tetracaine is the only ester that have longer duration of action. And the stability is that esters are less stable in a solution. They break down easily, like I said. So they break down easily and they are unstable. So they are unstable and they have shorter duration of action. Why? Because they are broken down easily. While amide are more stable and have longer duration of action because they are slowly degraded in the liver by cytochrome P450 enzyme. So next is the mechanism of action. What is the mechanism of action of local anesthetic? So always remember mechanism of action. Local anesthetic, now going back to what we have just said, local anesthetic can be divided or classified under ionized form, which is lipid soluble and water soluble. Don't forget, lipid soluble and water soluble. So lipid soluble is the ester form, while water soluble is the amide form. So the two of them, they can exist at these two. But one thing you have to know, going to the lipid soluble can easily penetrate the what nerve membrane easily, while water soluble needs a carrier or needs to bind to a receptor in order to exert its what effect. So but now going with the lipid soluble, in lipid soluble, once they easily penetrate the nerve membrane, what do? They enter into the exoplasm and is converted to an ionized form. Don't forget. So lipid soluble, first of all, enter, it pass through the axolemma. So axolemma is the what plasma membrane around the what axon. So it passes through the axolemma easily. So when it passes through the axolemma, it enters the exoplasm. When it enters into the exoplasm, from the lipid soluble, it converts to water soluble, which is unionized form to ionized form immediately. So but ionized form has to bind to a receptor there before they can be taken in by endocytosis. But one thing you have to know, for lipid form, they penetrate truly, but when they are inside, they convert back, and when they convert back, their work is to block the sodium channel. So when they block the sodium channel, what happens? Sodium will not enter, and with sodium not entering, what happens? It will block the what? Depolarization. Don't forget, first of all, unionized form enter into the exoplasm, is converted back to ionized form, and if it's converted back to ionized form, its sole aim is to block the sodium channel, and once it blocks the sodium channel, it prevents depolarization and propagation of what? Action potential. And if there is no depolarization, there will be what? Hyperpolarization. The opposite of depolarization is what? Repolarization. So when there is no depolarization caused by sodium, there will be repolarization caused by what? Potassium. Don't forget. So this is what they are doing, and when they will prevent action potential, and when they will, instead of action potential, they will cause what? Resting membrane potential. So what will they do first? So in order of the blockage, now who will they block first? Who will they tackle first? They will target sensory fibers first. Then after sensory fibers, they target what? Motor fibers. So sensory fibers will come first, motor fibers will come next. So the first sensory fiber, they will first start with what? Small myelinated sensory fibers first. Small myelinated sensory fiber first. So they don't just block sensory and motor at the same time. No. First of all, they first block small myelinated sensory fiber, which is what? Pain and temperature. Then they go to large myelinated sensory fiber, which are what? Touch, pressure, vibration. They block them next. You get it now? So you are touching pain and temperature first, and you are touching what? Touch, pressure, vibration later. Then before lastly, you now block the motor. So first of all, you first block the sensory fiber and you block the motor fiber. But the first one is the pain and temperature. The next one is what? Touch, vibration, pressure. Then lastly, you now block the motor. This is how they work. They just block the sodium channel, preventing depolarization. But first of all, we are using the unionized form. So if unionized form enters inside, they convert to water soluble, which is ionized form. Then from there, block the sodium channel. Now for the pharmacokinetics, now the pharmacokinetics is simple. First of all, talking about the absorption. How can they be absorbed? Naturally, they depend on the site of administration. So if you are giving any patient the drug, it depends on the site of administration, whether you are giving it IV, IM, or anyhow you are giving it. So it depends on the site of administration and the presence of the vasoconstrictor. So that is what is dependent on, the site of administration and the presence of vasoconstrictor. So when you are giving epinephrine will reduce the absorption. So when you are giving epinephrine alongside local anesthetic, and the epinephrine will reduce absorption and prolong duration of action, which reduces what? Toxicity. So when you are giving the vasoconstrictor alongside local anesthesia, it's more helpful because they help to what? Reduce the toxicity and cause what? Prolong what? Duration of action. Now again, the distribution, because in pharmacokinetics you can group them into what? Absorption, distribution, metabolism, and excretion, which we will talk about in our pharmacokinetic video. So once we talk about absorption based on the site and the presence of vasoconstrictor, the distribution is based on if there is what? Presence of large vascular system. So when you put it in an area where there is vascular blood supply, a lot of blood supply, it gets to be absorbed more, and there will be an increase in systematic what? Absorption and distribution. I always say it, Esters local anesthesia can be what? Degraded and hydrolyzed faster by what? Plasma what? Pseudocholesterol. So plasma pseudocholesterol, which is what? Butyric cholesterol, breaks down Esters local anesthesia more faster, especially the parabenzoic acid, which cause what? Allergic what reaction? Which causes what? Allergic reaction. Amide local anesthesia degrades slowly by what? Cytochrome P450 enzyme located in the liver. So after they are what? Absorbed, distributed through the blood vessels to the nerves, and when maybe you inject it directly to the nerve causing a block, then what happens? They are metabolized, and in the kidney they are what? Excreted. So very, very simple. Very, very simple. Now for the clinical notes, so what is the therapeutic use or the clinical notes, where you what you should note about their function specifically? Always know that. Now for topical anesthesia, what happen? They can be rubbed on the body or used as eye drop in order to what? Cause what? Numbness in that area you are about to work on. Are you getting me now? So you can put on the skin, mucous membrane. Say for instance, I'm working on the teeth now. You get it now? I'm working on the teeth. That is a mucous membrane. Now I'm working on the tongue and I want to numb that area. What happens? I give it. So it can be used on the skin, on the mucous membrane, on the cornea. Now, if it's used mostly on the eyes now for cornea procedure, especially the use of lidocaine, tetracaine, benzocaine, and cocaine. So you can use all these things for cornea what procedure. Now, infiltrate anesthesia now. Infiltrate anesthesia. What can you use for infiltrate anesthesia? They are used for subcutaneous injection for minor surgical procedure. Infiltrate anesthesia for minor procedure. Minor procedure. So you give them subcutaneously. Don't forget. But for topical agent, you put them on the skin, mucous membrane, and cornea. But infiltrate anesthesia, they are used for minor what procedure. So you can use lidocaine or procaine. Lidocaine or procaine, which is what? Short acting agent and intermediate acting agent. But procaine is majorly used for this reason. So for nerve blocks now, what is nerve block? Maybe you are giving injection on the major nerve, especially when you are doing a dental surgery. So when you are doing a dental surgery and you are giving an injection on that area, so what happens? It causes nerve block there. So you are targeting directly to the nerve. So what you are doing is for use for dental procedure, use for orthopedics, and use for spinal what? Surgery. So once since we know this one, the next one is spinal anesthesia. So remember, topical agents or topical anesthesia, you have what? Infiltrate anesthesia, you have nerve block anesthesia. Can use it for spinal anesthesia. So spinal anesthesia is very, very important. You inject it directly to the what? Subarachnoid space. So when you inject it to the subarachnoid space, it can cause numbness directly to that area. And you should know the first place that gets to be blocked is the sensory area. So the sensory area, which is a small myelinated fiber, go to the large myelinated sensory fiber before the motor fiber. So in the next one now, you're talking about spine. Okay, the next one we're talking about the spinal anesthesia. I told you that it's given directly to the subarachnoid space. And the only drug you can use for this is what? Lidocaine. Those that have eyes, especially amide. So you have lidocaine, you have propivcaine, and you have tetracaine. So they are used directly for this what purpose? Spinal anesthesia. Do not forget. The next one is epidural. In epidural, you give it into the epidural space. Now remember, you have all your dura mater, you have your arachnoid matter, and you have your pia mater. So outside the dura mater, you call it epidural. So when you give it to the epidural space, what are you doing? It's used commonly in labor and delivery. So when you are giving it epidural, but when you are giving your spinal anesthesia, you are giving directly to the subarachnoid space. Now it can also be used in intravenous regional anesthesia. We call it bear blocks. So if you are giving intravenously to block a region, I get him now, to block a region. So who do you use? Lido and perilocaine, which is what? Intermediate acting what? Agents. Now the next one is surface application in what? ENT what? Procedure. What's ENT? Ear, nose and throat. So when you are giving it in ear, nose and throat surgery to block that particular area, what do you use? Use cocaine. So cocaine causes what? Vasoconstriction and what? Anesthesia. Very, very important. And also it can be used as an antiarrhythmic agent too, especially. So when we're doing antiarrhythmic drugs, you remember we talk about lido. So lido is given IV for what? Ventricular what? Arrhythmias. Don't forget. So it can also be used as an antiarrhythmic agent used to also do carry out the same function. So remember, topical agent, infiltrate, nerve block, spinal anesthesia, epidural anesthesia, IV what? Regional block, cord bear block, and antiarrhythmic what? Agent. When you remember them, you have remembered the what? Therapeutic use of this drug. So it will be asked mostly in your exams. So make sure you read it very, very well. Make sure you read it very, very well. So ENT surgery, you use cocaine because it causes vasoconstriction to reduce bleeding. Obstetric and gynae, where you use epidural, you are using propivcaine because they have longer duration of action. You also use them in spinal anesthesia to target the subarachnoid space. Now for dental surgery, to use lidocaine. So dental surgery, use lidocaine to block the nerve directly. Arrhythmias, you use lidocaine. Now the next one we're talking about is the side effect. So what side effects are they giving? So specifically, they have different side effects. So the first one, we'll talk about the side effect to the CNS. So when you are giving patient local anesthesia, you will also have a reflex side effect they'll be giving you. So not that they are numbing that area, they're also causing a side effect for you. So first one now, we have our initial phase. So in initial phase, what happens when you give them? So there will be psychomotor numbness, there will be tinnitus, this patient will sense metallic taste in the tongue, and also there will be lightheadedness. Why are you doing now? You are blocking sodium gated channel and causing what? Hyperpolarization. So there will be lightheadedness, there will be tongue numbness, feeling metallic taste in the mouth. The next one now, you enter the excitatory phase. In the excitatory phase, what will happen to the patient? There will be what? Tremors, convulsion, and what? Restlessness. So that is in the excitatory phase. So the initial phase is what happens initially, numbness and everything you need. But there will be tinnitus, there will be metallic taste and lightheadedness. But in the excitatory phase, there will be tremors, there will be convulsion, there will be restlessness. While in the depressive phase, there will be drowsiness, there will be coma, and the patient can go into respiratory arrest. Why will the patient go into respiratory arrest? Because the drug can also weaken the respiratory muscle, so the patient will not be able to respirate. Also, you are decreasing sodium channel blockers in the brain, causing what? Increase in what? GABA. So when you are increasing GABA in the brain, what happens? It's causing what? Drowsiness, and the patient can go into coma by inhibiting the ascending reticular activating system, so the patient can go into coma. In the CVS system, what will happen immediately? To remember that you are causing hyperpolarization, so it's having an effect in the SA node, causing what? Bradycardia. So once you cause bradycardia, it can also cause what? Also decrease in blood pressure, causing hypertension. So you can cause bradycardia, you can cause hypertension, depending on, and you can cause what? Arrhythmias. So you can also cause arrhythmias, because if you are relaxing that area, what happens? You are what? Vasodilating the blood vessel by you relaxing that area. And if you vasodilate the blood vessel, that is why they give them what? Epinephrine. They also give them epinephrine too. So now propivicane, particularly propivicane is very bad for the heart. Why? Because it causes cardiotoxicity. For your exams, propivicane causes what? Toxicity, because it causes what? Ventricular arrhythmias. So don't forget propivicane. But one thing that lidocaine is used to counter what? Ventricular arrhythmia. So propivicane, bad for the heart. Bad for the heart. While lidocaine is good for the heart, because it is used to treat what? Ventricular what? Arrhythmias. Also allergic reaction. Remember, all esters causes what? Allergic reaction, because the parabenzoic acid what? Metabolite. For myotoxicity, it increases potassium inside the muscle, causing mild water relaxation. So it can be toxic to the muscle. Why? Because it prevents sodium to enter, causes what? Electronegative ion inside the muscle. So don't forget myotoxicity. And also neurotoxicity. It causes neurotoxicity, especially when you use lido. So when you use lido and you put lido in the subarachnoid space, remember the subarachnoid space of the spine is also connected to the subarachnoid space of the brain. So it flowing through the brain, what will it do? It can cause transient or neurological symptoms. Transient neurological symptoms, like it will cause relaxation, so the patient will be drowsy, and it can also inhibit the ASA, ascending reticular activating system. So I hope it's making sense to you. So it can cause neurotoxicity, myotoxicity, can cause arrhythmias, especially when you are using propivicane. So be mindful when you are using propivicane. All esters can cause allergic reaction, and if you cause allergic reaction, what happens? You are stimulating the what? IgE, which is what? Immunoglobulin E. So if you stimulate immunoglobulin E will bind to mast cells, releasing histamine, and histamine will cause relaxation of the blood vessel. Don't forget. So that's why all esters can cause allergic reaction, and allergic reaction causing the release of mast cells. Do you know there'll be vasodilation of the blood vessel, and if there's vasodilation, hypotension will occur. And if there's hypertension, what happens? Also bradycardia will occur. Why? Because they'll be inhibiting the what? SA node. So bradycardia can also occur. So there can be edema, because it will vasodilate the blood vessels, causing also edema. So also know all these things. So when you are using perilocaine and benzocaine, you should also know. So when you are using perilocaine and benzocaine, you should be mindful of what? Metamoglobinemia, due to oxidation of hemoglobin. So when you oxidize hemoglobin, it gives you what? Metamoglobinemia, and you should be mindful of it, because these patients, when they have oxidized their hemoglobin, which means they'll be dropping hemoglobin in the blood, causing toxicity. Why? Because there'll be oxygen will not be binding to any receptor. Oxygen will not be binding to hemoglobin, therefore there will be no dropping of oxygen to the tissues, therefore hypoxia will set in. So always be mindful. It makes sense for you like this. So connect it. I want you to connect it because it makes sense. So you remember there's neurotoxicity because of you are giving it to the subarachnoid space. There will be myotoxicity due to absence of depolarization and hyperpolarization. There will be what allergic reaction, which causes the release of histamines, and there will be what bupivacaine causes cardiotoxicity. So hope it's making sense to you, and hope you are understanding it small. So it's making sense. So I want you to also connect it very well and connect it so that you will understand it. So sometimes in the head too, it can cause seizures. So no, it can cause seizures due to a reflex excitation in the brain. It can cause seizures. Very, very important. So cardio, now you should remember there's hypertension there. So since we know this one now, the next one is prevention of toxicity. How can we prevent toxicity when this drug occur? First of all, use lower effective dose. First of all, so you use lower effective dose. So when you use lower effective dose, there will be lower risks of what any organ toxicity or the toxicity in the blood. Next one, use aspiration before injection. So you aspirate before you inject to prevent what intravascular what administration. You aspirate first before you what inject. One is using a lower dose. Two, you aspirate before you inject, and also add what vasoconstriction there, or you add a vasoconstrictive drug alongside, especially epinephrine, to reduce what systemic what absorption. Because if you do not add it, what happens? There will be high systemic absorption, which will cause what toxicity. So always add a vasoconstrictor to any local anesthesia you are using, and also use what lipid emulsion therapy. So when you are giving them, you should also add lipid emulsion therapy just to rescue the lipid there. Why? What? Because to prevent what systematic what high what toxicity, especially when you are using what bupivacaine. So are you getting me now? First of all, you are giving them the effective dose they need. Second, you use add vasoconstriction when you are giving them. Why? To prevent what its toxicity. So you should also know that to prevent the toxicity, you can also add vasoconstrictor alongside with it. Now, what again can you do now? When the patient is being toxic, you also stop the drugs. You stop the drugs and you give enough what oxygen. Stop the drugs and give enough oxygen, and also support the airway. Are you getting now? Support the airway. So anytime there is seizures, always use benzos. So when there is seizure, you use benzos. And what benzos? You can use what? For diazepam, lorazepam, or midazolam. So in case there's seizures, in case there's increase in what activities in the brain due to you putting it through the what subarachnoid space, so there can be seizures there. And when there's cardiotoxicity, especially when you are using bupivacaine, I've said it, use IV what lipid emulsion therapy to rescue the lipid. Are you getting me now? And anytime there's what methemoglobinemia, especially when you are using perilocaine and benzocaine. So when you are using both of them and the patient is having methemoglobinemia because of you are oxidizing his hemoglobin, then what you use? You use methylblue. So methylblue will cancel the action of methemoglobinemia and reduce it back to what hemoglobin. So anytime you are using any of these drugs, you should also be mindful that any of these can happen, and you should also take care of the patient by giving them all these things. I told you when the seizure uses benzos. Also, to prevent its systematic toxicity, you use epi. Also, when the patient is having methemoglobinemia, you use methylblue. And when there's cardiotoxicity, you use IV lipid emulsion. And when there's a lot of toxicity, you stop the drugs, give oxygen, and support the airway. So recent advancement has been made towards local anesthesia. So those that can cause toxicity has been reduced. Are you getting me now? So the recent advancement I will give you because of your exam, because it's what is currently happening now. You get it now. So the recent advancement now, instead of bupivacaine, because of its cardiotoxicity, there's a presence of level bupivacaine now. So level bupivacaine is a single enantiomer of bupivacaine, but now it is less toxic. Now, so instead of bupivacaine, they are now giving level bupivacaine. Now, instead of what atticane, so atticane now is used in dentistry now. It's used in dentistry because of its rapid onset and its metabolism. So if they use it quickly to carry on what dental procedure, atticane. So remember, atticane has two eyes, so atticane falls under what amides. There's one that is a neuromuscular blocker, but they always pair them with what local anesthesia now. It is called Sugamendex. So Sugamendex is a neuromuscular blocker used alongside with local anesthesia. So when you remember Sugamendex, you know that they always use it alongside with what local anesthesia. So Sugamendex is a neuromuscular blocker. Don't forget. So atticane is used in dental procedure. Level bupivacaine is used instead of bupivacaine, which is less toxic to the heart. Ultrasound guided regional anesthesia. ultrasound guided regional anesthesia. It is safer and more accurate than normal local anesthesia. So they are using ultrasound to guide regional anesthesia, giving anesthesia, but not directly, but through the help of ultrasound. So hope you have understood. Now we have given you all this because of your exams. So all these are added stuff you need because of your exams. So now hope it all made sense. It all made sense to you, and I've explained everything you need to know about local anesthesia. Local anesthetic are essential drugs that provide irreversibly loss of sensation. We say they are classified under esters and amides. Are you getting me? Classified under ester and amide. Like I said before, esters have one eye, amides have two eye. And now it is clinically important because due to the difference in metabolism, duration of action, and causing allergic reaction. So always know esters causes allergic reaction. Why? Because they are degraded fastly. They are degraded fastly and they have shortest duration of action. Now they are widely used in general anesthesia, obstetric and gynecology. They are also used in dentistry, in emergency medicine. So very important. Now why they are highly effective, they can cause systematic toxicity, allergic reaction, and cardiovascular complication, especially when you are using propivicate. And now before you select the drug, you have to do dosage adjustment, and you have to know the appropriate agent, and you have to add them with some drugs in order to reduce their toxicity. So that is when you are using them, especially in clinical practice. So hope all this thing makes sense to you. Hope it all makes sense to you. So this is just a general overview of local anesthetic. In my last video I talked about skeletal muscle relaxant, but in this one we are talking about local anesthetic. So now remember it. Do not forget all the mnemonics I've given you and how you can best remember it. Now if you are new to my channel, make sure to subscribe and turn on your post notification button, so at any time I drop any video, you'll be sure to be notified. And if the video is more fast for you to understand, because I just want to round it up to make it so it will not be big. So if it's so fast for you, make sure to just slow it down, and also use your textbook to read it alongside. This is just an overview, and follow the description I've been given on the slide, so you can pause it, write down what I wrote, and also listen to me so that you will follow and know the connection, how I connected it, while this drug causes all these things step by step. So I'll be seeing you in my next video. Bye bye.